Welcome back to our series on concepts in mapping and ablation, and we are continuing with timing of bipolar and unipolar electrograms in the setting of focal atrial tachycardia. In the previous section, I mentioned that the shape of the unipolar electrograms is independent of the direction of the wavefront. However, in a bipolar electrogram, the shape of the electrogram is dependent upon the direction of the wavefront. So, as I mentioned, the bipolar morphology is based on wavefront orientation. For instance, if the wavefront is moving in this direction, it will cross the distal electrode first. When it does, the bipolar electrogram will reflect the distal unipolar electrogram, and you'll see the first rapid component will be a downstroke. And then as the wave crosses the second electrode, we'll see the component that comes from the second electrode. Remember, we're going to invert this. And so if you invert this, it will be an upstroke. And so the second component is going to be an upstroke. And that will give us an M shape to the bipolar electrogram. When the wavefront is moving in this direction, it will cross the second electrode initially. And so remember, we invert this potential, and so the first rapid component is going to be an upstroke. We'll then cross the distal electrode and get this component, which will be a downstroke. So now the bipolar electrogram will have kind of a W shape. And you could imagine that as we rotate the catheter around, we're going to get every possible combination between these two shapes, between the W shape and the M shape. So there is no single shape that's characteristic of a bipolar electrogram. It depends on the orientation of the wavefront relative to the electrodes. And again, for timing, remember, we always annotate, or we always select the local activation time as the first rapid. So if the second electrode is encountered first, the wave is going to have a W shape, where the first component is an upstroke, whereas if the wave encounters the tip first, the first component is going to be a downstroke, giving you the classic M shape that we always draw as a bipolar electrogram. The catheter is occasionally oriented perpendicular to the tissue. In that case, the distal electrode is in contact, and as the wave crosses, you get a typical unipolar electrogram on the tip electrode. The ring electrode, or electrode 2, is going to see the same timing that electrode 1 sees. As that wave crosses, it will record the same timing, but this electrode is located a distance away from the tissue. So the potential is going to be smaller, and it's going to be a lesser slope. It will be less steep or rounder. In other words, this is a far-field electrogram. So when we subtract the small or low amplitude signal from the second electrode from the tip electrode, we get a bipolar electrogram that looks somewhat like the distal unipolar electrogram. And this electrogram looks and times like a unipolar electrogram. But because it's a bipolar electrogram, it won't see far field. It will have to get very close to the electrode to generate any sort of signal. So it has a very small recording range. So this electrogram, even though it's a bipolar electrogram, it looks in times like a unipolar electrogram and has several advantages. Being a bipolar electrogram, it eliminates far field potentials, and it also eliminates the 50 hertz or 60 hertz noise that we get when we use the Wilson central terminal as a reference. We call this kind of bipolar electrogram actually a close unipolar electrogram because we can use it for timing. And so anytime the ring or second electrode is not in contact, we have this close unipolar electrogram when we record in the bipolar mode. So this is actually a better way to record the unipolar electrogram. The first catheters to use the non-contact reference for unipolar recordings will be the Octaray, which has a central electrode here that will be the non-contact reference, and the Atrial catheter, which will use a ring electrode on the hub as the non-contact reference. And these improve the resolution of the unipolar recordings by eliminating the far-field signals. Let's talk about the Wilson Central Terminal. Current mapping systems and recording systems use the Wilson Central Terminal as the reference electrode for the unipolar electrograms. The Wilson Central Terminal is the average of the three ECG limb leads, the right arm lead, the left arm lead, and the left leg lead. Here is a patient with a macro-reentrant left atrial tachycardia, and you see an ablation catheter in the left atrium. Here is the proximal bipolar electrogram, the distal bipolar electrogram. This is the unipolar electrogram from the ring or the second electrode, and the unipolar electrogram from the tip electrode. And notice that when you record the unipolar electrogram with a Wilson Central Terminal, you typically see 50 hertz or 60 hertz noise. And many physicians will say, oh, my equipment is noisy, oh, my room is noisy, but actually not. This is quite typical and normal in any room. The reason you get a 50 hertz or 60 hertz noise with a Wilson Central Terminal is at least twofold. First, the differential amplifier is designed to receive inputs that have the same impedance. And when you have a mapping electrode with a low impedance and the skin leads forming the Wilson Central Terminal is the high impedance, that's one cause of the high noise level. The second reason, and probably more important reason, is that the cables for the ECG leads and the cables for the catheter electrodes travel in different locations in the room. And the room has lots of pieces of electrical equipment. Each piece of equipment generates an electromagnetic signal in 50 hertz or 60 hertz that is picked up by any cables that are traveling near them. And since the cables travel in different parts of the room, they see these different pieces of equipment and so get different amplitudes of that 50 hertz or 60 hertz noise. And so when you subtract them, they don't cancel. The reason the bipolar electrograms don't have much 60 hertz noise is that the wires from the electrodes in the catheter and the cables are right next to each other. So they see the same amplitude noise from each piece of equipment, and when you subtract one from the other, you eliminate that noise, and that's called common mode rejection. Because the cables are traveling in different parts of the room, you don't have common mode rejection, so you've lost that. And that's probably a very big cause for the noise level. The Cardo system has an algorithm that actually measures the 50 hertz or 60 hertz signal and subtracts it from the electrogram without altering the rest of the signal. The recording systems that electrophysiologists use don't have an effective system like that. So electrophysiologists typically use a notch filter to deal with that noise. Well, what does the notch filter do? Here is a figure from an excellent review article by Jacques Debacker and Fred Wittkampf. And the figure legend says that this is a unipolar electrogram recorded at the tricuspid annulus. And notice these potentials are very close together. To me, they look like a ventricular and atrial potential. And I suspect, it doesn't say what the rhythm is, but I suspect that they were mapping retrograde atrial activation to localize an accessory pathway, a right-sided accessory pathway. Well, if this is the ventricular and atrial potential, it's easy to assign timing or annotate the atrial signal. You know, you could just take it at the most rapid part of the downstroke there, and the same would be true for the ventricular signal. And then they turned on the notch filter. When they applied the notch filter, the signal changes significantly. You can see that every little glitch becomes a potential. So that if we were to look at timing, we might be able to say, well, okay, this is going to be the timing of the ventricular electrogram, but where do you want to select for the atrial electrogram? It even altered the baseline. It took the little potentials in the baseline and made them quite large. They were often as large as 1/10 of a millivolt. And this is larger than many of the isolated late potentials that we look for when we're doing substrate mapping in a ventricular scar. So the artifacts would look like isolated late potentials. So you can't use a notch filter if you're going to be doing substrate mapping. And I'll show you another problem with the notch filter in this particular case. So here was a left mid-septal accessory pathway that Elad Anter and I were mapping. And you can see we're mapping with a transseptal catheter here. The catheter is across the annulus here. And you can see the mapping catheter in the LAO projection is up against the septum. The pacing catheter for pacing the ventricle is positioned in the posterior coronary vein to pace the basal left ventricle, to pace the basal ventricle close to the accessory pathway. And so we're going to be pacing the ventricle, looking retrograde, and the distal bipolar electrode is going to be on the ventricular side of the annulus. So the annulus is probably located somewhere around here, and the proximal pair is going to be located in the atrium. So here is the electrogram. Here's the left ventricular pacing stimulus here. And you can see this is the proximal bipolar, distal bipolar electrogram on the ablation catheter. And you can see that the distal bipolar electrogram is in the ventricle. And you can see that the proximal electrogram is in the atrium. And here you see a retrograde accessory pathway activation potential. That's pretty cool. And so Elad was working the catheters, and so he wanted to pull the catheter back to record the pathway potential from the distal electrode. And as he did, the tip bumped against the pathway potential and made it fire. And when it fired, you have a pathway potential here, then you have retrograde conduction to the atrium, and you have antegrade conduction to the ventricle. Here you can see the onset of the QRS complex, and you see ventricular activation here about 20 milliseconds before you have ventricular activation. But actually, that's not why I'm showing you this example. The reason I'm showing you this example is you can see the ringing in this electrogram that told us that the notch filters were turned on. And it didn't have too much impact on the distal bipolar electrogram. We could tell that this was the real signal, that this was the pathway potential. The atrial signal is still pretty intact. Ventricular signal is pretty intact. But look at the proximal bipolar electrogram. Here you have the atrial signal. And remember, with the bipolar electrogram, we annotate to the first rapid. That would be right here. But my inclination is that this first rapid was a tiny signal that was made sharp by the notch filter, that the real local atrial activation is here. But you can't be sure because of all the ringing. It's a more significant problem here. Here, it only differs by about 4 milliseconds. So that may not be that big an issue when it comes to timing. But if you look over here, if we take the first rapid, this would be the signal that we would time the electrogram. But I suspect this was a small signal that is far field, and that really this is the local activation, but that this signal was made sharp and looking like it's the real timing signal because of the notch filter. So we elected to turn the notch filters off to complete the mapping. I'll show you an electrogram in a moment to compare, and at that time we were mapping antegrade. So let's look at this electrogram to compare. So we'll move this over to the left here, and now this is the electrogram with the notch filter off. And you can see that we're pacing the atrium, so we have antegrade conduction over the accessory pathway. You can see the pathway potential here. Notice there's no ringing, it's very clear. And look at the atrial signal. Look how easy it is to time here. You can see that this little signal probably would have been made big like over here, but you can actually see the correct timing of atrial activation, as you can see the correct timing of atrial activation here. And it was not, this first signal was not made especially big and sharp by virtue of the filtering. So you have much crisper, cleaner, easier to identify electrograms with the notch filter off. So I never use notch filters. So in order not to use a notch filter, I can't use the Wilson Central Terminal with my recording system as the reference electrode for unipolar recording. So I need something else. I need something that doesn't have these two problems. I need something that has the same impedance for both the mapping electrode and the reference electrode, and I need something where the cables travel together so that they see the same noise and you have common mode rejection to get rid of that. So the only thing that's going to accomplish both of these is to use another catheter electrode. So we need that catheter electrode to be out of the chest, and so we could have it in the inferior vena cava. And so for probably the last 30 years, I've used a catheter that I place in the right atrial appendage that has 6 electrodes. 5 of the electrodes are very small and closely spaced, and they're at the tip of the catheter, positioned in the right atrial appendage. The proximal most electrode, the 6th electrode, is located 25 centimeters from the tip, so it's in the inferior vena cava. And I simply make a bipolar electrogram where I put the mapping electrode in the plus, and the 6th electrode goes into the minus input. We record the bipolar electrogram, and that gives us a unipolar recording. Now you can use other electrodes. There are other catheters that are made like that. For instance, the DecaNav is a 10 electrode catheter that has an 11th electrode farther back. That'll be in the inferior vena cava. Or you could use really any electrode in the inferior vena cava, and that would work fine. What does it look like when we change from the Wilson Central Terminal here, and I put here 60 hertz because this was in the United States where we recorded this from the left atrium, and now we've changed to the inferior vena cava electrode. The catheter is not exactly in the same location. You can see the atrial signal is a little larger, the ventricular signal is a little bit smaller. We didn't change anything other than the reference electrode for the unipolar recordings from the Wilson Central Terminal to the inferior vena cava, and now you can see the electrograms quite clear and sharp. It's very easy to time the atrial signal here, whereas imagine timing the atrial potential here. I guess you would take it somewhere along here or somewhere along here, but really you don't really know what's in here. And it's really very helpful to be able to get away from the Wilson Central Terminal, and that allows you to turn off the notch filters. Let's start looking at some cases. So here we're mapping a focal right atrial tachycardia. We're using an ablation electrode. Here are the surface leads, and here are the electrograms recorded from the ablation electrode. So here's the proximal bipolar pair, the distal bipolar pair, and here are the unipolar electrodes that go with this distal bipolar pair. I typically like to place all my electrograms with proximal on the top and distal on the bottom. So while many people place unipolar here to be right next to the bipolar electrogram, I often like to place my second unipolar electrogram here and then the distal unipolar electrogram. Well, this is an ablation electrode, so the mapping system marks the location of the tip of the catheter, so we always want to record the timing of the tip of the catheter, so that means we're going to measure the activation time from Uni 1, which is the distal electrogram. We're going to take it from the sharpest component of that downstroke in the unfiltered electrogram, 1 to 500 hertz. And if we only had the bipolar electrogram, right, we would take the first rapid and we take the sharpest component of the first rapid, and you can see that both of these are simultaneous. They're both giving you the same activation time, and the reason is that the wavefront hit the distal electrode before the second electrode. So how do you know when you're at the site of earliest atrial activation so that you can ablate a focal tachycardia. Well, everyone knows that that's going to be when the unipolar tip electrogram, when the unipolar electrogram begins with a steep negative component. Why does it do that? Let's say the focal origin is right here, and we have the mapping electrode directly against the tissue right at that site. So activation is going to be progressing away from that site, and remember, there will be a small positive charge in front of the wavefront and a negative charge on the back side of the wavefront. The electrode right over the focus is only going to see the negative charge. And initially the charge will be strong, and as the wavefront moves away, that charge will get weaker. So initially you get a steep negative potential, and then that potential will get progressively less negative as that wavefront moves away. And some people like to call this a QS pattern. In every map I have ever made, there's always at least one place, usually only one place, where I can see a perfect QS electrogram that is not at the site of earliest atrial activation. In other words, there's a little isoelectric interval before the downstroke. Because this occurs, we use actually 3 criteria to pick the site of earliest atrial activation rather than just the unipolar morphology. The unipolar morphology is the 3rd criterion. So the first criterion is that we are never at the site of earliest atrial activation until the activation that we record is at least as early as the earliest recorded far field potential. Remember, the far field is that rounded part of the electrogram, and as you look at all of your catheters, any signal, any electrogram, you can see where that signal begins, and that is the beginning of the far field potential. So on your mapping system, you can put a timeline on the screen, a caliper or some other timeline, and as you move your mapping catheter progressively closer to the site of earliest activation, you will see progressively earlier and earlier far field activation. So you continue to move the caliper or timeline progressively to the left. At some point, that caliper or timeline will stop moving to the left. That tells you that you have found the earliest far field signal. Your electrode is not at the site of earliest activation until local activation on the bipolar electrogram occurs at least as early as the earliest far field activation, which is at the caliper or timeline. We recommend that along with the mapping system, you do this same process with your recording system. Every recording system can be set on trigger sweep and use a fast sweep speed. I like 200 millimeter per second. That's the same sweep speed that we use on the mapping systems. And put a timeline. It could be a caliper, depending upon the recording system. Some allow you to use special timelines that you can move. And we place it at the earliest far field, and as we find an earlier signal, we move that timeline to the left and to the left, and I'm going to show you an example of how we do that in just a moment. And at some point that timeline stops moving. That tells you you're at the earliest far field. Okay, so then we continue to move the catheter, the mapping catheter, until we actually see local activation that is at least as early as that earliest far field. And when we do, we've met the first criterion. At that site, we look at the second criterion. And we do that by comparing the time of onset of the distal bipolar and the distal unipolar electrograms. If they begin at exactly the same time, we know that there's no far field activation any earlier. So if we meet both of these criteria, we know we're very, very close to the site of earliest activation. Then we want to make sure that the tip or the ablation electrode is at that site of earliest activation. And so then we look and see if the unipolar electrogram begins with a steep negative component. So let's look at an example and see if we can demonstrate how we do this. So Here we're mapping a focal right atrial tachycardia. Here are the ablation electrograms. Here's the proximal bipolar, the distal bipolar, unipolar 2, unipolar 1. And I want you to notice that on all my electrograms, you'll see that the recording gain is relatively low. I like to use a relatively low recording gain because that allows me to easily tell what's rounded and what's steep. And you can differentiate that. Then you always have to pick a reference. In this case, we're going to use the right atrial appendage electrogram as our reference. That makes that time 0 on the map. And let's look at our far field timing just at this site. So if we look at this electrogram, the far field activation begins at this site. If we look at the proximal bipolar electrogram, it begins at this site. If we look at Uni 2, it begins here. If we look at Uni 1, it begins here. And the earliest of all of these is on Uni 1. So we're going to move our timeline over here to the left. And this is 34 milliseconds before the reference time. And it turns out that when we kept moving all of our catheters and everything else, we never found a far field signal any earlier than this. So this becomes our earliest far field atrial activation. But just because this is the earliest far field doesn't mean that our local time is here. In fact, our local time is not here. Our local time is going to be based on unipolar 1, so it'll be the timing of the rapid component of the downstroke, and you can see that that time's only 24 milliseconds before the reference. In other words, it's 10 milliseconds later than the earliest far field. That means this site is at least 10 milliseconds later than the onset of activation at the focus. And 10 milliseconds could be as far as a centimeter away. It's certainly way too far to ablate. You want to be within 2 or 3 milliseconds of that earliest far field activation. So let's look at some other electrograms. Let's move this over to the left here, and let's look at a second electrogram. And wow, look at the distal unipolar electrogram. It begins as a steep negative. So is this our ablation site? What do you think? What am I not showing you? I never turn off that earliest far field signal. Notice this is not synchronous with the earliest far field activation, because there is an isoelectric interval here. This was the one place in this map where we have a beautiful QS, perfect QS electrogram, but it is not at the site of earliest atrial activation. So until you're right as early as the earliest far field, you are not at the site of earliest activation. So what is the real activation time here? Well, it's going to be based on the downstroke of the unipolar electrogram. It's 28 milliseconds after the reference. So that's 6 milliseconds later than the earliest far field activation. So that's still too late and too far away for ablation. So let's look at another site and see what you think about this site, whether this would be a site that you would target. Well, let's look at activation. On the bipolar electrogram, we have activation at and synchronous, or times with, the earliest far field activation. So that meets our first criteria. This was the first criteria, that local activation is at least as early as the earliest far field. So that's our first criterion. So then we're going to compare the timing of onset in the distal bipolar and distal unipolar electrogram, and you see that they begin at exactly the same time. That tells us there's no earlier far field activation, so we are very, very close to earliest activation. We want to make sure that it's the distal electrode that is at earliest activation. So now we're going to look at the morphology, and we want to make sure that the distal electrogram begins as a steep negative, and these gains are very low. I neglected to tell you earlier, I always use half the amplitude on my unipolar electrograms than I use on the bipolar electrograms. And you can see that this is a very low gain signal, and yet it's still very steep. Nothing is coming towards us. There is no positive component coming towards us. Everything is moving away. So this fulfills all three criteria. We are dead on at the site of earliest atrial activation. So yes, this would be a good site for ablation. So we delivered the first RF application here. As soon as we turned on RF, there was one beat of tachycardia, and then tachycardia terminated and was not reinducible. We delivered a couple of extra RF applications, but actually it was eliminated by that very first application of RF energy. We will continue with more case examples as we move to part 3.